It is my sincere pleasure today to, excuse me, let me take care of this, present the GI update for 2026. My name is Dr. Cathy Eng at Vanderbilt-Ingram Cancer Center. This is kind of the layout of the presentation, really focusing on colorectal carcinoma and then anal carcinoma updates. And what do we know thus far? Well, what we do know is that we definitely have some new treatment options for frontline therapy. I just want to provide a friendly reminder to you that colorectal cancer still remains one of the leading causes of cancer death for men and women combined. And in 2026, the numbers will increase to 157,000 plus individuals that are impacted by colorectal cancer. The mortality will still be approximately 1/3 of the patients. And globally, this is still an issue despite screening guidelines. I also wanted to bring to your attention the fact that we've had some recent updates that were published in JAMA looking at the development of early onset in patients that are less than 50, and it remains basically the leading cause of cancer mortality. This was updated from data from 2023. This was just published in 2026 this year. When we think about colorectal cancer, we have to think about molecular subsets, and that's extremely important in the metastatic setting. And so all patients should be tested not only for microsatellite instability, regardless of stage, but in the metastatic setting specifically, they should definitely be tested with next-generation sequencing. And as mentioned in last year's colloquium, we do recommend testing as well if you're thinking about adjuvant aspirin for reducing your disease-free survival, so for checking for PIK3CA mutations. This is the BREAKWATER data, which basically was presented last year, but I wanted to give you a very recent update. So if you recall, this is specifically looking at patients with a BRAF V600E mutation. And basically, that is approximately less than 10% of our patient population, which is historically a poor prognostic indicator. And these are MSI stable patients. Patients were randomized originally to FOLFOX plus Encorafenib plus Cetuximab, standard chemotherapy, or the refractory standard regimen at that time, Encorafenib and Cetuximab. And we want to look at it in the frontline setting. The study was eventually reduced to 2 arms, recognizing that Encorafenib and Cetuximab would be insufficient, in the treatment-naive setting. And the primary endpoints here were progression-free survival and overall response rate. As you can see here, the progression-free survival was in favor of the chemotherapy plus Encorafenib and Cetuximab, once again in treatment-naive BRAF V600E patients. And for the doublet, it was 6.8 months, and for standard of care chemotherapy, it was 7.1 months. But more importantly, we had previously believed that these patients with standard chemotherapy, as demonstrated once again here, despite our best chemotherapy efforts, their median survival was only 15.1 months. However, with Encorafenib and Cetuximab plus chemotherapy, the survival was 30.3 months. And that really has now changed the new paradigm of care and really has allowed us to think that these BRAF patients have opportunities to not only participate in clinical trials, but should we consider surgical intervention, if appropriate, if they have surgically resectable metastatic disease. So this is very pivotal in regards to survival, given that the current survival rate for the majority of our clinical trials is anywhere between 32 and 36 months. The response rate obviously was very favorable. Once again, this was a primary endpoint of 66%. This is already, I think I mentioned this at last year's colloquium. But I want to give you some additional updates. So we did also do a post hoc analysis of early onset patients because, as I mentioned earlier, there is a rising incidence of early onset patients in the United States. And when we looked at our data specifically from the BREAKWATER trial, and the early onset patients versus the average age onset patients, meaning those that were less than 50 versus those that were equal to 50 or greater, you can see here that despite our greatest efforts and this being the best treatment option for BRAF V600E patients, the overall survival of these patients in the early onset patient population is much less than the average age onset patient, which indicates to us that if you have a BRAF V600E patient, please initiate full combined systemic chemotherapy as much as possible, especially in the setting of an early onset patient. Why is this happening? Once again, we are doing further analyses on our findings, and we will update this once again in the near future. So I'll share that information with you when it's available. We also had updates looking at cohort 3, which is looking at the combination of FOLFIRI plus Encorafenib Cetuximab. So not just a FOLFOX combination. The primary endpoint here was response rate. And here we report very similar response rate. So instead of 67%, here it's 64% in combination with FOLFIRI. And then just happened this week, yesterday. As a result, the FDA has since approved the BRAF-TOVI combination, so Encorafenib Cetuximab in combination with systemic chemotherapy, 5-FU-based treatment, either FOLFOX, oxaliplatin-based, or irinotecan-based treatment, regardless of which chemotherapy backbone. So this is breaking news. What other trials are available in the frontline setting? I think this is important to keep in mind. Once again, for our metastatic patient population, we need to definitely do next generation sequencing to optimize their overall care. I just want to remind you, please do test for HER2 amplification. This is present in about 4% of our patient population, and there's an ongoing trial of FOLFOX plus tucatinib and trastuzumab. Code Break 301 is looking at KRAS G12C, which represents only 2% of our patient population, but sotorasib plus panitumumab plus in combination with FOLFIRI is being evaluated as well in the frontline setting. And then the second line setting, we have the adagrasib combination that with final results pending. And then we also have the new agent, amivantamab, which, as you know, is approved already in lung carcinoma. So focused on a RAS wild-type patient population, looking at amivantamab in combination for the frontline setting called Origami-2 and the Origami-3 in the second-line setting. These trials are all open for enrollment. What about our MSI patients? So we've had a new update since I last participated in the colloquium. We have now data looking at MSI high patients, stage 3 patient population, and looking at the role of adjuvant atezolizumab in combination with oxaliplatin-based adjuvant treatment. Here, it was designed prior to the realization that we do not normally provide patients full 6 months of FOLFOX-based therapy in the adjuvant setting. So we do have to keep that in mind. And then as well, the atezolizumab was continued for the full duration of a year. And the primary endpoint was disease-free survival. Now, atezolizumab is a PD-L1 inhibitor. And this was the, I'm going to bring this up because I will show you another trial that is also utilizing this in a different setting, which has resulted in some questions. So sorry. So this atomic trial, basically a large component of the patients, about a third, were T4 and N2 patients. And then this was centrally confirmed in regards to MSI high testing. These were the forest plot for disease-free survival in favor for the investigational arm. It ensured FOLFOX and atezolizumab was able to demonstrate improved disease-free survival. However, what would I do in reality? Well, as we all know, we don't normally give 6 months of FOLFOX anymore. I think at 3 to 4 months, I think it's very reasonable to cut back to either stopping all chemotherapy or consider 5-FU-based treatment. And then atezolizumab, I think it's very reasonable to reevaluate with imaging at 6 months and then make a decision whether or not you would like to proceed for the additional 6 months in regards to the adjuvant therapy. Now, there are other ongoing trials in regards to the the locally advanced colon cancer setting. AZUR-2 has completed enrollment. We do not have those results looking at the role of dostarlimab. And then at this year's ASCO GI, we have an update regarding the COMMIT study was looking at the metastatic setting in regards to MSI high patients, once again, treatment naive patients. So this was the clinical trial design. So MSI high patients, treatment naive, they were randomized to basically FOLFOX, bevacizumab plus atezolizumab or atezolizumab alone. And the progression-free survival here was astonishingly low for the control arm of atezolizumab alone. If you recall, Checkmate 8HW, which we have presented in the past, the median progression-free survival was greater than 30 months. And here for atezolizumab alone, it was 5.3 months. The overall survival was also not statistically significant. So this trial has resulted in a lot of additional questions. And I think we will need to determine we need more data to really decide why this occurred in regards to such poor single-arm progression-free survival in this setting. What about anal carcinoma? We have a couple of updates. I want to remind you about the UK trials, Act 4 and Act 5. Act 4 was specifically at an early stage, T1, T2, less than 4 centimeters, node negative tumor. Patients were randomized to receiving 41.4 gray or 50.4 gray as the standard of care. And then Act 5 actually looked at dose escalation for so larger tumors, node positive. Does it help to dose escalate in order to improve disease-free survival? So Act 4, it was published. I do not have any graphs. However, early interim results basically demonstrate that a reduction in radiation therapy at 41.4 gray was actually just as good as the standard of treatment. Once again, these are early results. And then Plato Act 5 was just presented at ASCO GI, looking at, once again, dose escalation in larger tumors, node-positive tumors. And here there was no additional benefit for dose escalation of radiation therapy. Now, in the United States, we have 3 trials that are currently pending, all supported by the NCI and supported by ECOG. This is EA2165, which is looking at that high-risk patient population, those with tumors greater than 4 centimeters, node positive. After completion of chemoradiation therapy, they were randomized to 6 months of adjuvant nivolumab. I hope that we will have these results shortly. The primary endpoint is disease-free survival. Very similar to Act 4 in the United States, we have EA2182, which completed enrollment about a year and a half ago, and we hope to have some of those results in the near future. Once again, not only looking at reduced dose radiation therapy, but also looking at the role of just a single dose of mitomycin C, so only week 1 and not weeks 1 and 5, which is the standard of care. This is called the DECREASE trial and supported by the PI of Dr. Jennifer Dorth. In Europe, we are waiting for the results of RADIANCE, which looks at the role of durvalumab in combination with concurrent chemoradiation therapy and whether or not this improves disease-free survival. And then for the metastatic setting, I've already presented podium 303 in the past, looking at the role of chemotherapy with retifanlimab, which has received FDA approval in the United States because podium 303 was largely conducted in the UK and overseas. In the United States, we had EA2176, which was also a phase 3 trial in treatment-naive patients. This includes correlatives, including HPV circulating tumor DNA. The primary endpoint was progression-free survival. Here, there's no crossover because nivolumab was already approved in the second-line setting. And we also completed enrollment about a year and a half ago, so we're looking forward to those final results. So thank you so much for your attention. And if you have any questions, please feel free to reach out. Take care. Bye-bye.